Plain X-ray is one of the first and basic modality to evaluate the shoulder joint. Let us refresh the anatomy of the shoulder girdle first. The shoulder girdle consists of the clavicle, scapula, and proximal humerus, and their associated ligaments and muscles. The scapula has a complex structure consisting of the flat triangular body with superior, medial, and lateral borders. The scapular spine is a projection on the posterior aspect of the scapular body which terminates in the acromion. An anterior protrusion called coracoid process. The glenoid is a shallow saucer-shaped projection from the lateral aspect of the scapula which articulates with the humeral head. The glenoid is oriented anteriorly by around 30 degrees. The proximal humerus comprises of four major parts: the anatomical head, greater tuberosity, lesser tuberosity, and the shaft. The anatomical head and the tuberosities make up the surgical head of the humerus. The surgical neck of the humerus lies at the junction of surgical head and the shaft. The clavicle is a S-shaped bone that articulates with the acromion of the scapula laterally to form the acromioclavicular joint. Because of the complex osteology of this region, no single radiographic projection shows either the true shape or the true position of any of the bones of the shoulder girdle. A shoulder radiograph series may be needed for evaluation of arthritis, trauma, instability, or impingement. For the antero-posterior view of the shoulder, the beam is oriented in the sagittal plane. This shows the clavicle, acromion, and a good view of the acromioclavicular joint. The proximal humerus is also visible well. However, since the glenohumeral joint is normally anatomically tilted around 30 degrees anteriorly, this projection results in overlap of glenoid and humeral head. AP view can be taken either in external or in the internal rotation of the arm. In external arm rotation, the greater tubercle is in profile laterally and the lesser tubercle is superimposed on the humeral head. In the internal arm rotation, the lesser tubercle is in profile medially and the greater tubercle is superimposed on the humeral head. The AP view allows good evaluation of fracture or dislocation and can also demonstrate abnormalities in the settings of chronic shoulder pain, including calcific tendinitis or bursitis and acromioclavicular joint arthritis. For the true AP view of the shoulder, the beam is oriented in the plane of the glenoid. This view allows better assessment of the integrity of glenoid and congruity of the glenohumeral joint. The anterior and posterior rims of the glenoid cavity are superimposed. Lateral aspect of the coracoid process slightly superimposes the humeral head. Correct amount of caudal angling is evidenced by a clear view of the subacromion space. The true AP view demonstrates the integrity of glenohumeral joint and shows fractures. For the axillary view, the patient has to be able to abduct the arm to about 45 degrees, which may be difficult after an acute injury. In such a situation, the modified axial view can be done. For the modified axial view, the patient with his arm in a sling leans back 30 degrees over the cassette, while the beam is directed from above. The axillary view is a top-down view through the shoulder and gives a clear image of humeral head and the glenoid and their antero-posterior relationship. This shows fractures and dislocations of the proximal humerus, osteoporosis, osteoarthritis, Hill-Sachs lesions, and osseous Bankart fracture involving the anterior glenoid rim. The scapular Y view is a direct lateral view of the shoulder useful to evaluate the relationship of humeral head with glenoid. Lines through the acromion, coracoid process and the body of the scapula intersect at the center of the glenoid. The humeral head is centered on this intersection point. This view is useful for delineating the fractures of coracoid process, scapula, acromion process and the proximal humeral shaft. The scapular Y view is also used to evaluate the contour of the undersurface of the acromion process when classifying the acromion. To every trauma radiograph that you see, you must always apply the ABCS approach. Here A stands for adequacy, B for the bones, C stands for cartilage and S is for the soft tissues. To see the details of interpreting and reporting a trauma radiograph in a methodical and scientific manner, please check out our video on how to read a trauma radiograph. The link is in the description. That's all for now on the basics of shoulder radiology. If you want more such videos, please let us know in the comment section below.